2,400,000, and there are close to 70,000 deaths here, and 300,000 deaths here, and hazard ratio is 1.15. So these people have 15% higher risk of dying from type 2 diabetes. And also they have a higher risk of dying from cardiovascular disease. What is interesting here is, okay, the excess deaths from cardiovascular disease is much higher in younger age group people. So I want to open up some kind of discussion here at this point. Can anyone kind of take a stab at it and see why younger people have a higher risk of dying from all-cause mortality and CVD mortality in type 2 diabetic patients? I just want to open up and see, what's your thoughts on it. What would be the physiological, biochemical might explain this phenomena? And we always think, older people would have a higher risk of dying.
So Muntaza said, because patients are living with the disease for longer.
Okay. The younger people are living longer, so older people are living longer, so they know how to manage it.
Well, they're living with the disease for longer if they're diagnosed earlier. I think that's the point he's making.
Okay.
The second suggestion
but what about why the mortality? Right.
Yeah,
why the mortality is so high in younger people?
Yeah, the second suggestion is that they're not younger people may not be serious about controlling their HbA1c.
Absolutely, he hit the nail right on the head. Absolutely, I think younger people, they tend to ignore it, and also they may not visit the doctor as much. Maybe they have it, they may not go to the physician on a regular basis. And I have a perfect example of one. He was 40-year-old, a friend of mine back in Atlanta, and he had a sugar of 130, 140. He said it's not a big deal. I don't have any symptom. I keep on telling him, you got to go, but he never listens. He never understands what it means. So anyways, so that's very true. Any other thoughts?
There's another suggestion that with the increasing prevalence of obesity in younger people, could that be a factor?
Yes, I would think so. The higher rates of obesity and higher rates of type 2 diabetes, and obviously that may be linked to mortality also. It's perfect. Any other thoughts from the audience?
That's all we have for now, Dr. Vijay.
All right.
Already diet is much poor.
Diet is poorer among younger people? Is that what Dr. Zumi said?
Yeah. Yes.
Yeah. Yes, I think so. I would agree with you. Probably they may not pay attention, or they may be ignorant, or they may not be paying attention to the diets and physical activity. Physical activity would also be problematic, perhaps. Maybe the physical activity is relatively lower in younger people, because of the job they sit in these days, and everything is in front of the computer, and they don't have to move to make any money. So perhaps that could also be a reason: physical activity and diet. I agree. Well, just a little bit of physiological biochemical explanation behind obesity and type 2 diabetes. The obesity actually leads to type 2 diabetes. Okay, so if you can somehow control obesity, you can prevent it. So let's look at what's the connection, how obesity can lead to type 2 diabetes. Obese means you have fat cells, okay, especially subcutaneously, as well as in the abdominal area. So the fat cells, especially in the abdomen area, are prone to secrete more adipokines. So the fat in the abdomen is more dangerous when it comes to type 2 diabetes compared to the fat under the skin. So when you identify people with increased waist circumference, So they are at a higher risk for type 2 diabetes because they carry lot more fat cells. That means they carry a lot more adipokines in their blood system. So these adipokines are simply pro-inflammatory. And these are the adipokines: leptin, interleukin B, TNF alpha, resistin, plasminogen, inhibiting factor, serum amyloid A. So you name it, there are a bunch of pro-inflammatory markers that are produced by these adipocytes. And as you know, adipocyte is a dynamic tissue. It's not a lazy tissue. It's an active endocrine tissue. Okay. So these inflammatory markers actually involved in insulin resistance, and they can also reduce the insulin secretion, more likely. So as a result of this insulin resistance, pancreas must work harder to control the blood sugar. Pancreas eventually burns out. So sometimes a type 2 diabetic patient could become insulin dependent. And eventually, as they grow older and older, the longer you live, more likely the type 2 diabetic patient, when they were starting with the metformin, maybe at the end stage, they may need insulin shots or combination of both. Are there any discussion points on this? Anyone has any points to bring it? Can you hear me, Zakaria? Dr. Zakaria?
Yes, we can hear you, PJ. So at the moment, there's no further questions.
Sure, no worries. The BMI definition is simply, you already know it, so I'm not going to spend too much time on it. It's just the ratio between weight and height. And in the United States, they still use pounds. So this is the equation for pounds, and this is the equation for metric system. And the conversion factors, all right? And these are the classification of obesity based on BMI. And again, most of you are very familiar with this, so I'm not going to get into details. Simply, the obesity is categorized into 3 categories: grade 1 category, grade 2, grade 3, or class 1, class 2, class 3. Okay, so 30 to 35 is considered grade 1. 35 to 40 is grade 2, and anyone more than 40 is considered morbid obesity. And the risk of cardiovascular disease, risk of other comorbidities are much higher as we go from class 1 to class 3 obesity. And here is another reference material for you. It's a body mass index calculator. You can it's kind of one-stop shopping. You can use this one for all patients. Okay, you can kind of pinpoint exactly where the patient falls. You can categorize overweight, obese just based on BMI. Okay, this is how you measure the BMI. Okay, and you identify the upper hip bone. Okay, and kind of snug the tape on the skin rather than pressing it, and come around and measure the waist circumference. Okay, so this seemed to be the better marker when it comes to identify the patients who are at higher risk for diabetes, because simply these people have abdominal fat. Okay, higher abdominal fat. So again, this is how you would measure. Okay, and then of course this is not the waist, and this is the waist from upper hip bone and probably around the navel region. So obviously the waist circumference is a better marker, but BMI we use more often. Okay, because of the ease that we can do BMI. Okay, and studies have shown it moderately correlates with body fat, not highly correlates, but moderately correlates with body fat. Okay, easy to measure. It's used very commonly in several very large epidemiological studies. It's non-invasive, even compared to waist circumference. Okay, this is really non-invasive, relatively inexpensive, good sensitivity and specificity. Reference data exists. It's been used for a few decades, It started in 1985. Okay, since 1985, we've been using this BMI, and child BMI also correlates with adult BMI. Okay, and this also correlates moderately with CVD risk, long-term mortality. The BMI should only be used as a screening tool, not as a measurement of body fat. Okay, because a person who is very heavy can have a high BMI, especially athletes. In athletes, it overestimates. In older people, it underestimates the body fat, because as we grow older, we become less, we accumulate more body fat. As a result, in very old individuals, in muscular individuals, the BMI should not be used. It's not very accurate. In some populations, it can miscalculate, especially Asians. They may have even a higher risk with lower BMI. So maybe they may have to, they have different types of, you know, the phenotype is a little bit different compared to the Western population. So the BMI that we use in Western population may not be applicable to Asian population. Okay. So these are some of the limitations, some of the strengths. I want you to have some discussion here. See if you guys can come up with any other limitations that you can think of, any other strengths that you can think of that I have not covered from your practice, from your perspective, so that we all learn from each other. Any comments or any discussion when it comes to limitations of BMI?
There does seem to be one question, Dr. BJ, around. Can you add some clarification? There's one question around.
The clarification is that, you know, are there any other limitations or strengths you can think of that are not listed here?
So there's a question around the use of BMI in other populations in certain cultural subgroups. What are the limitations?
Limitations is simply the BMI categories that we use for Western population may not be applicable to Asians. That means, you know, the risk for certain BMI, let's say, for example, you know, the risk of having a disease at 30 to 35, if you define a risk of a disease, that risk may be a little bit much higher in Asian population for the same BMI. Okay, so the Asians should have a lower cutoff value for obesity. That's what it means. It miscalculates the health risk. Maybe 25 may not be normal BMI for Asians. It may be maybe 23 perhaps. Obesity 30 may be too high for Asian populations, perhaps. Maybe it should be maybe lower. So we don't have specific BMI. What is Asians? How much is for Asians? But what we are using is the Western population in a BMI. It may, especially Middle Eastern population, the Asian population, may not be applicable. Maybe Dr. Zoomin can add something to it when it comes to Asian population and BMI.
Yeah, the Asians have much lower cutoff.
Yes.
Yeah.
Exactly. And then Asians also include Middle Eastern also, you know, have a little bit less cutoff value. It may not be 30, it may not be 25 for overweight. It could be little bit less. Any other comments? Any other questions, please?
Yes. So in response to your question regarding the strengths and limitations of BMI, one of our participants have mentioned that the people who have high muscle mass due to working out may not be at increased risk of diabetes, but can have a high risk of BMI.
Absolutely. Absolutely. That's one of the limitations of BMI. It may not be applicable to all populations. It certainly, overestimates the risk of disease for athletes because they have more muscle mass, they have higher bone mass. So as a result, they may have a BMI of 35 or 32. And if you go blindly with the risk versus risk and then BMI, you would categorize them having higher risk. So the BMI has limitations. Athletes, it's not applicable. And also for older individuals, because we lose lean body mass as we get older. So as a result, the person may maintain the same BMI when the person was younger, but the body composition has changed. When the person was 25-year-old, he or she may have a BMI of 25. When the person became 60-year-old, that person may still have the BMI of 25, but the body composition has changed. So you could be leaner obese. Okay, that's what we call. Some individuals are very skinny when they're older, but they have type 2 diabetes. It's very common these days, and that's due to sarcopenia, reduced muscle mass, increased body fat. So sarcopenia is one of the reasons why some leaner individuals may suffer from type 2 diabetes. Did I explain that? Are there any comments further?
So there's just a couple of further comments around the limitations of using BMI in pregnancy.
Yes,
and
absolutely.
also in patients with comorbidities that may cause them to have fluid retention.
Absolutely. So the BMI cannot be applicable. Even lactating women also sometimes you may have a wrong BMI. So pregnancy and lactating women, it may not be applicable. Yes, patients with
Seems as though we've lost
well,
Dr. Vijay.
I'm sorry.
Work on resolving this issue. I do apologize.
Can you say again, Dr. Zakaria? I could not understand. Hello, can you hear me? Did I lose you? Hello? Hello?
I can hear.
Can
We
you
can
hear
go
me?
ahead. Looks like there's some connection issue, but you can go ahead.
There's some
Yes,
connection issue.
yes, we can hear you now, Dr. Vijay.
Okay. All right. You were saying something earlier, Dr. Zakaria.
Dr. Vijay, can you hear us? Yes, please.
Yeah, I can hear you. All right. Let's move on to the next slide. Yes, BMI has limitations. Okay, but BMI has been very widely used. However, there are other methods that are much better than BMI. They are highly precise. The measurement error is much lesser, such as underwater weighing, bioelectrical impedance, using the caliper, skin fold thickness measurements, waist to hip ratio, DEXA. So these are all much more sophisticated, and the accuracy is much more. So these methods measure the body fat percentage. Yes, you can use these methods in a smaller scale level, but especially in larger based studies, in epidemiological studies, in a population screening studies, these are not really practical. And there are some drawbacks, user error. So you got to be very, very skilled in using these machines. If you do not know how to use these machines, you will introduce error, lack of access. It's not like everyone has access. It's expensive, these machines, especially DEXA, very expensive. So because of these limitations, we are still using BMI as a surrogate marker to define obesity. All right. Any comments or questions?
So there is just one further question regarding BMI.
Okay.
So in what age do you think that BMI is no longer applicable for older people?
That's a very good question. It's a very, very intelligent question, actually. I don't think, studies have shown that that this particular age group, it would not be applicable. But in general, I would say, maybe 60, perhaps maybe 65. At that point, I think people start losing muscle mass and start accumulating body fat. But also it depends on the individual, though. If an individual is engaging in physical activity, they can retain their muscle mass. The people who don't engage in physical activity, having active lives, not having an active lifestyle, they perhaps lose muscle mass at a faster rate compared to someone who is actually involved in regular physical activity. So but not knowing the physical activity, I would guess around 60 years perhaps you would see some change in the body composition. Some individual, it could be even lower. Maybe in Asians it could be lower. Okay, but in Western populations around 60, 65 you will see. Any other thoughts? Any comments?
That's it. Thank you, Dr. Vijay.
All right. So how do we control overweight, and how do you lower your risk of getting diabetic? How do you lower your BMI? Well, there is a diet, physical activity, all those things. A diet, Dr. Zumin is going to talk next an hour. But I want to focus on lifestyle intervention, especially through physical activity. Okay. First, you have to speak with your doctor. Okay. What level of physical activity you should engage based on your body, whatever your body can do it for you. So that means, listen to your body and talk to the physician and see what you can do. Okay. And figure out how much time per day you can devote to exercise. So you got to kind of make it a chart. You want to do it, morning, evening, whatever it works for you. Set fitness goals. Okay. So you have to have clear goals, how you can help motivate it. Okay, that's very, very important. Having just goals is not enough. Make sure the goals that you're setting those goals is doable. Okay, you don't want to have unrealistic goals. A lot of times, people join gym on January 1st and they do it, very nicely, vigorously, studiously for a month or 2 months. Then the motivation goes down. It should not be the case. Okay, I think that's probably the biggest thing for a lot of people, not having motivation. Okay, initially they have motivation, but later on it dies. Consider where you will start. I think you have an option. You can choose gym, you can choose your neighborhood, or you can choose a park. Okay, whatever works for you. Okay, build different activities in your daily routine. Sometimes physical activity doesn't mean that you have to go to the gym. You can incorporate physical activity on a day-to-day basis. Little thing that you do on a daily basis could make a huge difference at the end of the year. Okay, and start slowly. Again, you don't want to start at a higher rate and you could get hurt. So make sure initially you allow for some time for recovery. Okay, and keep log of what you're doing and listen to your body. And these are the recommendations that given by American Diabetes Association. Okay, and I want to draw your attention to two types of exercises that people are generally engaged. One is aerobic. Can anyone tell me what is aerobic exercise? Why it's called aerobic? What kind of exercise is called aerobic?
We don't have any responses. So we have one response. So exercise that raises the heart rate. Somebody else says running would be considered aerobic exercise.
Absolutely, they're all correct. The aerobic exercise simply means your muscles get oxygen. Okay, that's why aerobic, in the presence of oxygen. So your muscles will never run out of oxygen. So that means you're not doing exercise very vigorously, but you're doing like jogging, not sprinting. Sprinting does make muscles run out of oxygen. Okay, light walking, treadmilling, maybe 2 to 3, what do you call, miles per hour walking. So those type of things are considered aerobic, like yoga exercise, Pilates, Tai Chi. So these are all considered aerobic exercises. So aerobic simply means you get oxygen to your muscles. So that means there is no lactic acid accumulation, not as much. Okay, but the benefits are plenty. Simple walking for half a kilometer or so on a daily basis would give you enormous benefits to your health. So don't ignore walking from one building to another building. If you have a walk to do to another building, don't take a vehicle or anything, just walk. Okay, so whatever works. If you want to go upstairs, just don't take elevator, maybe take stairs. So something like that. Okay, so the benefits are enormous. For example, you can increase your HDL, you can lower your LDL, and you can lower your blood pressure. Overall, your metabolism increases with aerobic exercise, and it ultimately leads to loss of weight, and also psychologically makes you feel better. And for type 2 diabetes, it lowers blood sugar. Okay, and this blood sugar lowering effect can last up to 24 hours when you do this aerobic exercise. You will also experience blood sugar during exercise and up to 24 hours. So if you do 3 to 5 times a week, you could have a pretty good control over this blood sugar. Okay, over a period of time, when you do this regular physical activity, body becomes a bit more efficient in processing your blood sugar. Okay, and also you improve your insulin sensitivity. Okay, so can anyone tell me exactly what kind of magic this physical activity does when it comes to insulin sensitivity? How physical activity improves insulin sensitivity? Is there a physiological reason, a biochemical reason? What exactly physical activity does to insulin? Anyone?
Ali has said that physical activity increases the uptake of glucose into the muscles.
Yes, the insulin sensitivity increases because the receptors they become sensitive to insulin binding. Earlier it was not. When the person is having fat in the cells, when he was not engaged in physical activity, they become a little bit, I guess maybe lethargic, perhaps lack of better word. So as soon as you start doing physical activity, those receptors become a bit more active. They bind nicely, and they allow these glucose transporters open. So as a result, the glucose can get into the cell. Okay, and also over a period of time, when you're doing exercise, in fact, the glucose entry into cell is insulin independent. So you develop sugar control with less insulin. So over a period of time, that's the biggest benefit if you do exercise over a period of time. So hey, I did today, and I'm not going to next 1 week. It doesn't work that way. If you really want to have a long-term sugar control, if you really want to, if you're a pre-diabetic, if you really want to prevent becoming diabetic, you want to engage physical activity on a long-term basis. Okay, so in the long-term physical activity would actually reduce the need for insulin. Okay, insulin sensitivity improves. That means you don't need insulin actually to push the glucose into the cell. Okay. So that's the beauty of having long-term physical activity. Okay. According to the Diabetes Association, according to the standards of medical care in diabetes, they recommend 150 minutes of moderate intense aerobic exercise per week. So I hope, you know, at the end of this session, most of you would get up and get some exercise or physical activity. On the other hand, anaerobic. Can anyone tell me quickly why certain activities are called anaerobic exercise, and what type of exercises come under anaerobic physical activity?
So we have one response. This is when the
Sure.
oxygen has been exhausted and there is a buildup of lactic acid.
Absolutely, absolutely. So anaerobic means, you know, your muscles are not getting enough oxygen. So when your muscles are not getting enough oxygen, you get tired. So that means, you know, you're doing vigorous exercise. Without knowing, we do combination of both anaerobic, aerobic exercise. Initially, it will be aerobic, but if that aerobic activity continues for a longer period of time, you automatically get into anaerobic exercise. But purely, if you want to look at anaerobic exercise, the severe way, the weightlifting, for example, is a perfect example of anaerobic exercise. You cannot lift weight forever. Maybe for a short period of time, you may do like 10 reps or 8 reps, and you're done. You get tired. Okay, so why it is? Because muscles are not getting enough oxygen. Okay, you create oxygen debt in the muscles, and also you produce lactic acid. Glucose undergoes anaerobic oxidation. That's why it's called anaerobic physical activity. So under anaerobic conditions, glucose gets lactic acid. Lactic acid is circulated in the blood system, and it can also accumulate in the muscles. You get muscle sore. So these are some of the consequences of anaerobic exercise. Okay. It also helps you improve muscle strength. That's one of the greatest benefits of anaerobic exercise, is that you will improve muscle strength. What it means is that you can maintain the muscle mass. You will not end up having sarcopenia later in life if you build, you know, muscles when you're a younger age. Okay, so the build up muscles that you have in the younger age would last longer. So you can kind of, you know, delay the onset of sarcopenia, or you can delay the onset of type 2 diabetes if you develop muscles when you're younger. The anaerobic exercise also improves insulin sensitivity. It also lowers blood glucose. Okay. It burns more calories, improves your heart health, lowers blood pressure. You can get the same benefits regardless of the type of exercise. Okay, and the American Diabetes Association recommends you should do 2 to 3 resistance training. And again, you need to consult with your physician what type of resistance training you want and how much lift you can tolerate, things of that nature. Resistance training, perfect example is body weightlifting. And I have another one last paper. Let's see how we're doing with the time. And I have another 10, 12 minutes. I want to finish my talk with this paper. Okay. This paper was published in JAMA. Okay. This is relates to obesity and all-cause mortality rate. Okay. And obesity was defined by BMI. In this study, they included 90. In this study, this is a meta-analysis study. They included 97 studies. Okay. And they had a sample size of close to 3 million. And in those 97 studies, 270,000 deaths were reported, and they calculated hazard ratios. Okay, so I want to define what these hazard ratios are. You know, we already talked about hazard ratio. It's slightly different from odds ratio and relative risk. Okay, let's say hazard ratio 2. What it means is that the treated population may die at twice compared to control population in a given time frame we are looking at. It could be 5 years, 1 year, or 1 month, whatever. Okay, so 1 is the standard. Okay, and you go above 1 hazard ratio, and likelihood of dying from a particular condition compared to control people is higher. Okay, so if you have a 3 hazard ratio, that means the population is 3 times likely to die with the disease compared to control population. Okay, so the higher the number, higher the hazard of death from the condition. Okay, I was going to show you a video due to lack of time, and I'm not going to show. This video is the video clip of a couple of minutes from the author of the study. Okay, so here are the findings of this study. It was published in 2017 by Center for Disease Control and the National Institute of Health. They looked at the various studies until that point, and they summarized the results from various studies. Okay, compared to normal BMI, which is 18.5 to 25. So compared to the normal BMI, the mortality risk for overweight is 0.94. Okay, it's less than 1.0. If it is less than 1.0, it's less risk. 1 means no risk. Higher you go above 1 is higher risk. Okay, this is surprising. Okay, this is very surprising. You have overweight people 25 to 29, and the mortality rate is lower compared to normal BMI. And let's look at the other BMI categories. Okay, all grades BMI. That means everybody who has 30 and above. 25 to 30 is overweight, as you all know. 30 and above. So grade 1, grade 2, grade 3, all grades combined. So when you combine all grades together, and the hazard ratio is 18% higher than 1.0. So that means for all obesities, the risk from dying is higher, 18% higher. Okay, but if you just tease out only separately overweight, it's actually lower. Okay, when they looked at the grade 1 obesity separately, when they did that, okay, there is no difference between normal BMI mortality risk and grade 1 obesity risk. So grade 1 obesity means simply it's 30 to 35 BMI. They did not have any higher death rates compared to normal BMI. But when they combined grade 2 and grade 3, which is higher, okay, and the hazard ratio is 1.29, so they have a higher risk of dying by 29%. Okay, now I want to open up for discussion for next 7 minutes or so. Can anyone tell me why overweight is protective against mortality? And in some ways, obesity 1, grade 1, did not have increased risk of dying, although they have a BMI of 30 to 35. So this is kind of intriguing, the first one. Why the overweight is protective from dying, although it may be related to higher risk for diabetes. Okay, so it's kind of, these results are kind of counterintuitive, you may look at it, but again, there is a physiological biochemical reason why overweight could be protective against dying.
The participants can put their ideas in the chat.
Sure.
I think we need some further elaboration, Dr. Vijay.
Sure. Well, overweight individuals have a higher body fat compared to normal individuals. Okay. Can you hear me? Is there something wrong with the video? You can hear me, right, Dr. Zakaria?
Yes, we can hear you. Yeah.
Okay. There is some background noise coming from my end, and there is echo also coming from my end. Anyways, overweight means they have a slightly more adipose tissue. Okay. So how having that extra fat would prevent them from dying? Think about in a hospitalized setting. Okay. Think about having extra reserves of nutrients. Overweight means you have extra calories, right? So think along those lines.
So one of our participants is asking, could this be related to malnutrition?
Yes, it could be. Yes, it is. You're on the right track. You're on the right track. It is related to somehow malnutrition, especially if someone has a higher body adiposity. Okay, in a critical illness, these are all cause mortality. Okay, in a critical illness, okay, the fat will really help. Okay, so it helps save lean body mass. In a critical illness, especially cancer or any other illnesses that could that leads to loss of lean body mass, they have a higher mortality rate. If you lose about 30 to 35% lean body mass, the person is going to die. Okay, so if you end up in a hospital situation with normal BMI or less than normal BMI, okay, and in a critical illness, that person may not last longer. The mortality rate may be higher. Okay, so the people who have reserves of this body fat, okay, and that could be protective in critical illness. So by the time the illness takes course, okay, and they will be out of the woods. Okay, so the lean body mass, the faster you lose lean body mass, the higher the mortality. The overweight and the obese people, they preserve their lean body mass, they last longer, and in the meantime they could recover. Okay, makes sense?
Yes, it makes sense. And also, it could be related to the reference group. In a society where the overweight and obese is that high, then the normal weight group can be some kind of outliers, or even if they are having a normal BMI, they may have some underlying issues like smoking, or smokers may have a lower BMI, or
Yes.
or someone may just lost weight and they tend to the normal BMI group. So it also has something to do with the reference group.
Yes, exactly. And some of the studies, have adjusted for smoking, I believe, but I'm not sure, if that really applies, because the statistical analysis adjustment is very different from physiological adjustment. So, absolutely, I agree. Any other points anybody wants to add?
So our participants do want some further clarification on that. So the specific questions that we're receiving is around older age and the BMI reference. And the second question is around people with higher BMI may live longer if they do have cancer. So I think that there's just been some misinterpretation of what you said. So if you could just repeat the last couple of points again, please.
Are you asking me or Dr. Zoomin?
Well, either of you.
Well, go ahead, zoom in.
Yes, for the cutoff, actually, there's no consensus on the cutoff for the older population. I had a paper actually published a couple of years ago looking at the BMI and mortality among the oldest old, mean that among those aged above 80, we've got a large cohort in China, around 8,000 with were aged above 80 years and being followed for many years. And what we found, it looks like the lowest risk is for those with BMI around 27. Looks like 27 is a appropriate, maybe a cutoff for the older population. But I know there's no consensus.
Yes, I agree. And in a hospitalized setting, especially, having a bit of body fat could be protective. Can you hear me?
Yes.
I think there's something wrong with the. Okay.
Yes,
maybe
I can hear.
Somebody unmuted their audio. That's okay. Anyways, in a clinical setting, in hospitalized setting, in a critical illness, especially, patients lose lean body mass pretty quickly because of the inflammation. And every critical illness patient has higher inflammation. So inflammation leads to loss of lean body mass. Okay, by having this little bit of body fat, it really helps preserve the lean body mass. Okay, so that could be potential explanation why overweight has associated with the lower mortality compared to normal BMI. And as Dr. Zumin said, a normal BMI doesn't mean they are healthy. Okay, so some of these studies we don't know the health status of what normal means. Yes, BMI normal, but it could be some people could be sarcopenic. They may have leaner, but they will have higher body fat. So but overall, certainly it seems like having a bit of body fat would be beneficial. It could be reserved against malnutrition. So overall, it could be protective. But again, it doesn't go linear way. Okay, it stops that relationship somewhere. So once you hit the grade 2 obesity, then the relationship disappears. Okay, you already start seeing the relationship with the grade 1. There's no relationship here. That means the grade 1 obesity is not really different from normal BMI. So it slowly started disappearing, the relationship here. It getting stronger with grade 2 and grade 3. Then you have too much of body fat here, I guess. So grade 2 is about 35 and higher. Grade 3 is 40 and higher, and they have a higher mortality. May not be from diabetes, but also from other type of morbidities, comorbidities. Okay.
I think that's made it. I think that's made it clearer, Dr. Vijay. Thank you very much.
All right.
Thank you.
Well, these are the discussion questions I had in mind. So we already talked about it. That marks the end of my conversation with you. The BMI, mortality, and type 2 diabetes, and the physical activity. Are there any other questions that you would like to engage with the speakers, me, Dr. Zakaria, or Dr. Zumin?
We'll continue monitoring for questions, and we'll put the questions to the speakers throughout the rest of the session today. Right. Dr. Zumin, I've now made you the host, and you will be able to begin your presentation now. Thank you very much.
So I will not be able to talk, right?
That's it now. So Dr. Zumin will be presenting now. Thank you, Dr. Vijay.
Thank you.
And diabetes and management. Yes, hello.
Yeah, you were muted, but you can now begin your presentation.
Okay, let me see.
You can begin now. Thank you.
Okay. Can you hear me?
Yes, we can.
Okay, yeah, thanks. So in this section, I'm going to talk about nutrition, lifestyle, and management in diabetes. And the learning objectives I've listed here, I have 4 objectives. The first one is to understand the NOVA food classification system. And the second one is to know the effect of so-called ultra-processed food, UPF, in CVD. And the third objective is to understand the current evidence relating the UPF and NCDs, including diabetes. And I also want to discuss a little about the current dietary practice among diabetes patients in Qatar. So we have different ways to categorize the food based on certain characteristics. And we may classify food based on their glycemic response, based on the glycemic index. We may say, well, some food may be unhealthy because they have high glycemic index or glycemic load. And we may also classify food based on the fiber intake or based on the energy density, whether it's high energy dense food or not. So we have different ways to classify food. But today, what I'm going to discuss is a way focusing on the food processing, how that can actually affect health. And that classification process, the system is called NOVA. If we look at this slide, let's look at the food. We start from apple, and that's the food we are familiar with. And then we have apple juice. And then we have apple pie. So although these 3 foods, they're all made from, or they're all from apple, but the degree of processing is different. For apple juice, well, it's slightly processed. But for apple pie, we barely see physically apple inside it. So it's in a way processed to a very high degree. And also inside the apple pie, we may have a lot of other stuff being added, especially you buy apple pie from the supermarket. So that is a way to look at the food based on the processing. And we say we have minimally processed food, we have processed, and we have ultra-processed food. The concept of so-called ultra-processed food, UPF, is actually, this definition is developed by a team at the University of São Paulo, and that was first published in Public Health Nutrition, actually in 2009. And since then, the concept was actually accepted or adopted by the UN, United Nations, WHO. And based on this classification, the system, we have a specific group called ultra-processed food. It means that for this group of food, the food has been gone multiple physical, biological, and chemical process, and among which the mostly of exclusively for industrial use. And they generally contain a lot of food additives. So that is the ultra-processed food, UPF. And based on this NOVA classification, the food we eat in our system, society, can be classified into 4 groups. Group 1 is the unprocessed, like the apple we picked up from the apple tree, the unprocessed food, or minimally processed food. The second one is the processed with some gradients, the process when we cook food. The third group is processed food. In this group, we may add some maybe salt, it's pickles, etc. In this food group, you can still see the shape of the food. It is food, but it's processed. And in the group 4, the actual processed food, actually you don't see the food itself at all sometimes. Like apple pie, you don't see apple. Or chips, you don't see the potatoes. So it's processed to a degree that you don't see the food itself at all. It's mixed with a lot of other chemicals. And if we look at the some of the list in this UPF, ultra-processed food, based on that classification, the first one is the carbonated drinks, the soft drinks. Do we see any food inside? Maybe sugar, we don't see. And mainly it's the food additives, coloring or some other chemicals. And the next one on the list is some kind of packaged snacks. And we have also ice creams, chocolate candies, all these confectionaries. And in this food, you don't see the original food. And we also have in this category some cakes or cake mixtures, biscuits. We also have breakfast cereals, the cereal or energy bars. And from this breakfast cereals, actually you don't see either the wheat or the real cereals. It's processed. There's a lot of other stuff being added, sugars, food preservatives. And we also have foods in this category, like processed cheese and sugared milk drinks and sugared fruit, yogurt, etc., etc. So these are typical processed food. And we also have more listed here: infant formulas, or the healthy so-called slimming products, fortified meals, etc. So we have a lot actually on the market, and we have sausages, burgers, hot dog, and these are all the actual processed food. So if you look at the list, it's so common, it's so familiar to us. If you go to the supermarket, they are on the shelf, in the fridge, they're ready to eat, or what you need is to put them into the microwave and heat it, then you can eat. So it's convenient, it's cheap, usually it's cheap, and it contains high amount of energy. It's energy dense. For some, it contains a lot of fat. And the consumption of ultra-processed food, if we look at the statistics globally, if we count the energy intake, and based on this food classification, NOVA classification, the group 4 food, the ultra-processed food consumption, contributes more than actually 50% of total energy intake in high-income countries. And in middle-income countries, it can contribute up to 30% of total energy intake. And here I have some studies or slides, results from the United States, the US. It was published in 2016 in BMJ Open. The data is from the NHANES, the National Health and Nutrition Examination Survey. The data is from 2009 and 2010. Quite large sample, 9,317 participants. And if we look at the total intake here of the ultra-processed food, the energy contribution to the total energy intake of the whole diet, ultra-processed food contributes, if you look at data here, is 57.9%. So more than half of the energy intake is from this ultra-processed food. And if we look at details of what contributes to the consumption, on the list here, we have bread, cakes, cookies, pies, salty snack, soft drinks, pizza, fruit drinks, breakfast cereals, etc., etc. So adding up all this consumption, and we have a contribution more than 50%. And it's quite often this processed food, they contain high amount of sugar. And if we look at the another column here, the relative contribution actually to the sugar, and can see that ultra-processed food consumption contributes almost 90% of the total energy intake from added sugar. So it's highly correlated with sugar consumption, the processed food. Just think about our breakfast cereals. Well, you may not be aware that the sugar, the content is that high, but it's been added actually a lot of sugar inside it. And similar consumption patterns can be seen in other developed countries, Western countries, and the list may be more in the years to come, because we just have so many actually food companies contributing and producing this kind of food, and they are available, they're cheap. And what could be the consequences of a high consumption of UPF, ultra-processed food? And the study in this area, in this whole area of ultra-processed food, if we do a so-called PubMed search, actually don't see many. Although this concept has been proposed long time ago in 2009, but we don't see many publications in this field. I just want to ask you, you just guess how many articles there may be in this area, if you do a PubMed search, can someone guess how many research are available or have been published? Can someone give a number? Is it high or low?
So we've got some participants saying 4 or 5, and other participants saying 10 or 20.
10 or 20. Actually, just before the I prepared this slide, I did a PubMed search. I used the keywords for ultra-processed food. I did a search, and in total, we have less than 500 records globally. It doesn't matter whether it's an animal study or it is a human-based study. But if you look at the publication, the journals, what journals they are published, mainly it's in the high-ranked journals. BMJ, JAMA, these kind of journals, and Cell Metabolism, very high-ranked journals. And next, I would like to show you a study, actually, showing what can be the consequence if we consume a high amount of UPF. Actually, it's a randomized clinical trial. It's conducted within the NIH, the US Central Lab. It's a crossover design, and the researchers recruited 20 participants and being allocated into 2 groups. One is the processed food, the other is unprocessed food, and 2 groups of people. One group, they consume ultra-processed food for the first 2 weeks, and then they switch to another diet. But the other group, they start with the unprocessed diet, and after 2 weeks, they change into processed, ultra-processed diet. And the results are striking, and the participants, they can eat whatever they want. And when the trial finished, the researchers analyzed the results. They found during the period of the consumption of ultra-processed food, the energy consumption is much higher, and they have much higher weight gain over the time. But on the contrast, the group consumed unprocessed food, the energy intake is lower, and their body weight actually goes down. So this study was published in Cell Metabolism, it's top journal in this field, Cell. That study was published in 2019, and since it's published, it's highly cited. And this is the study design. It's a crossover randomized trials, and they have detailed measures of blood samples or the DEXA data, and detailed information of food intake, how much food each meal they consume, the energy consumption, etc. Very detailed, very thorough examination. And maybe people may say that ultra-processed food versus unprocessed food, maybe the nutrition composition may be different. Well, in the ultra-processed food, you may have high, more energy dense, high fat, and high maybe some other stuff. And in fact, if we look at their menu, and they matched the nutrient profiles for these two types of diet. If you look at the slides here, for the ultra processed food versus unprocessed food, if you look at the nutrition profiles, they are quite similar. Even the fiber content and the fat content, the percentage, they are absolutely similar, except that the energy from processed and ultra processed food, the percentage is different. So it's the diet, the difference is not for the nutrients, but for the process, degree of process. And this slide shows the results, what they found during the trial, is that for the energy consumption, ultra processed food group, it's higher. And for the breakfast and the lunch, and they have much higher consumption. And for the eating rating, also eating rate, it's also different. The ultra processed food group, actually, people eat actually faster per minute. It's faster. If you look at the graph F here, it's much faster. And people also consume more energy from it. But interestingly, if you look at the protein intake is quite similar. And the percentage of energy intake from protein is quite actually similar in these two groups. So it has nothing, seems to be nothing to do with protein. I know here we have dietitians, and a lot of us will promote a diet with high protein to manage body weight, etc. I have a question for you. What are the benefits and the adverse maybe effects it could be for the high protein diet? Can someone comment on that, whether high protein diet is good or
so
or
I think we'll just allow participants a minute to put their responses in the chat.
Okay.
So Ali has said that there's a high chance that you're going to burn more fat.
Yes.
Mary has said that, is there a risk that you can break down muscle?
Yeah, high protein. I know there's a lot of actually debates in this area, high protein diet, whether it's good or bad. No, a high protein diet is used to manage body weight, to lose weight, and it's a big industry actually. There are lots of products there, and we recommend people to consume high protein diet. But maybe nutrition ecologists will say something on the other direction. A couple of years ago, I attended a presentation actually conducted by a professor of nutrition ecology in University of Sydney. And based on his research and others' research, is that human beings and the animals, actually we consume the diet, the protein contribution of energy is quite narrow, the range, the variation is narrow. And if you look at the animal, if their energy percent of from protein is higher, these are the animals with short lifespan, and means that high energy, high fat, high protein intake is not beneficial for longevity, and that has also been shown in many observational studies in population in humans. And in fact, the protein intake is regulated by human physiology quite tightly. And if we manipulate our diet and provide high proteins, it may not be a good solution. And the results from this trial is that the energy intake is much higher for the ultra-processed food, and the weight gain is high, and also the change in fat mass is high, or increased fat mass in the ultra-processed food as compared with the unprocessed food. So there is a significant difference. And we have a lot of, actually, some studies looking at population level, not the clinical trials, looking at the consumption of UPF and diabetes risk. As I said earlier, that we don't have many studies available yet. And in fact, we have only 2 population-based cohort studies available at this moment. So the first one is from France. It is based on the Nutritionate Center cohort. It's a large, very large cohort study from 2009 until 2019. It recruited more than 100,000 participants. It's a web-based survey, and this survey they use FFQ to collect consumption data, and then they use the data linkage technology to track the incident cases of diabetes from either the doctor diagnosis or from the pharmacy or insurance claim, etc. So the data linkage to ensure that the new incident cases of diabetes were recorded. And if we look at the consumption data in France, this table shows the overall consumption and also the breakdown by age and gender. And if we look at the values here, slightly different from the US study, here they presented the data as the percentage of the diet in weight, not the energy percent. And we can see that 17% of the food is from ultra-processed food in France, this study. And can see that for younger age and high consumption. And we have also slightly higher consumption in men as compared with women. So large sample. And what the results is here, if you look at the hazard ratio, is that if we look at the 10% increment of the UPF in the diet, it is associated with 13% increased risk of diabetes. So for every 10% increase in the consumption, the risk of diabetes increased by 13%. And this paper was published in JAMA Internal Medicine. And from the same cohort, there are other studies being published focusing on different health outcomes. We have cancer, published in BMJ, and also mortality, published in JAMA, and depression, and IBS, the inflammatory bowel disease, and also cardiovascular disease, again published in BMJ, all published in high-ranked journals from this cohort. And the other study, population-based study, is from UK Biobank. Again, it's a large study. It involves more than 500,000 participants. And what they found is the consumption of UPF in percentage of weight is slightly higher than the French population, 22%. It's high. And if we look at the individual UPF, the contribution, the number one is soft drink, fruit drink, and fruit juice. And the second one is the processed bread. So it's different if you remember the slide of showing the US, the consumption. Actually, the contribution from the different types of ultra-processed food, they're different. But although it's different, the association, the adverse effect actually is consistent. If we look at the hazard ratio here, same analysis method per 10% increment of the ultra-processed food consumption was associated with 12% increased the risk of diabetes. So it's quite similar to the France study. So what can be the explanation and the mechanism linking this ultra-processed food consumption and health outcomes? Can someone guess what can be the explanation? I give you 2 minutes maybe to think what can be the explanation for this link. And you've seen that the nutrition profiles for the processed and unprocessed diet in that clinical trial, it's exactly the same. So as nutritionists, we often always care about nutrients, energy density, fiber, all these nutrients. And it turns out the nutrients are the same in these two groups of diet. Then what can be the explanation? What mechanism can be? Can someone propose a couple of mechanisms?
So if we give the participants a minute or so to type their ideas in the chat.
Yeah.
Maybe if you just want to repeat the question again, Dr. Zumin.
What can be the potential explanation or mechanism which link the consumption of ultra-processed food and diabetes or other problems like obesity?
So we have one respondent, Ali.
Yeah.
He said, could it be a link to the preservatives contained in these foods?
Yes, exactly. That's one potential explanation. Yes.
The high fat content that leads to increased risk of cardiovascular disease?
Yes, it can be, yes. But not necessarily high fat in that clinical trial setting. The fat percentage is the same.
The lack of essential vitamins and minerals.
Vitamin and minerals, yes, it can be in real life in population studies, but that may not be the case for the clinical trial, that randomized trial. It's not the case.
What about food additives? What about food additives that are added during processing?
Yes, food additives, highly likely.
Would that be likely explanation?
Yes, we have so many food additives being added.
Exactly.
Yeah. Okay. I have an excellent review paper here explaining the potential mechanisms of this Western diet or ultra-processed diet and how it can affect the gut microbiome and leading to the metabolic disease like obesity, diabetes. And there are multiple factors. And when we look at the actual processed food and what we eat, the nutrients actually, they are from so-called acellular nutrients, meaning that nutrients are not contained in cells. So they are easily digestible. So when you eat this food, they can go quickly and to be digested easily. And if we eat the traditional, so in human history or evolution, nutrients have to be released from cells. And that process may take time, and by digestion, it takes time. The process is totally different. For cellular nutrients, the absorption, the pattern is totally different. They're easily digestible. And because of that, they can influence the gut bacteria growth. And they can even go to the colon and to affect the bacteria there. So the food we eat, all these cellular nutrients actually can affect the bacteria in the gut. And also the food additives you've mentioned. The use of food additives is huge actually. And these food additives, before their approval to be allowed to be put into the market, there's no need for the assessment whether they can affect the microbiota of the gut. It's not needed. It's not the part of the evaluation. And if we look at the food additives in the food being used, like emulsifiers, and there are many studies showing that these chemicals, they can change the microbiota composition and lead to gut inflammation. And they can increase the virulence factors and leading to the inflammation. That is one example. And here in that review paper, we have lots of food additives being added in this table and their effect on gut microbiota and the potential effect on the host physiology. We can see that we have lots of additives like CMC, it's widely used, and we also have the artificial sweeteners, etc. This P80, twin 80 is widely used. You can find it in the ice creams, cakes, etc. So these are the active components in the so-called ultra-processed food. If you look at the effect on the gut, the microbiota, and you know that microbiota play a vital role in the etiology of chronic diseases, including obesity or diabetes. So that can be one of the most important explanations linking the ultra-processed food and obesity and diabetes. And in addition to that, we have issues with food packaging. And for food packaging, we have plastic chemicals. And what we are familiar with is BPA and phthalate. And these chemicals, they can increase diabetes risk. And in fact, data from the ENHANCE shows that the ultra-processed food consumption is associated with high phthalate in the body, in the urine. That study was published in the Environment International. So there are multiple actually mechanisms linking this UPF with obesity, diabetes, or mortality, CVD, etc. So that is the something new, I would say, if we based on the number of publications available currently. Well, let's do some exercise. I give you a couple of minutes to think about. Write down the food lists you consumed today, or you analyze 124-hour food recall on diabetic patients. Let's count how many food items are UPF, and what is the percentage of the total energy intake of is from the UPF. And also, if you're interested, you can check what kind of food additives are added into the UPF you consumed today. And finally, I have another question. For those claimed vegan, what is the percentage of the food intake from UPF? I give you 3 minutes, maybe, to think about. Let's see what. Yeah.
Dr. Zhu, would you like participants to write it in the chat or just to write it on pen and piece of paper?
Maybe on the chat.
Okay. Dr. Zuman, we have some participants contributing their diet. There is a question also, and the question is about fructose level in ultra-processed foods and its relation to diabetes and obesity. Would you be able to talk about that a little bit?
Okay, let me see the question.
So this question is from Samaya. and it's about fructose level in ultra-processed foods and its relation to diabetes and obesity.
Would it harm? Okay, processed food can rise salt, more salt. Okay. More salt, more carb, because.
Dr. Zuman, are you hearing me?
Yeah. I cannot hear clearly. Yeah.
The question is regarding fructose level in ultra-processed foods and its relation to diabetes and obesity.
Yes. Yes, the level of process, the higher degree of the process, or the increased risk of diabetes and obesity.
Yeah, and more specifically about the fructose level.
Fructose. Now, probably it's a collective effect. There's no such studies specifically focused on fructose, but it's part of the problem, I think. Before we previously we look at individual maybe unhealthy components, but this concept of the ultra processed the food, looking at this type of food as a category, one category, so that we can address them collectively, so we don't actually differentiate to that degree.
Dr. Zuman, can I read you some of the foods that are being mentioned as part of the daily food list? So
yeah,
we have fruit yogurts, porridge with fresh fruit, a turkey sandwich, crisps, rice, and chicken curry.
Yes, some of them are definitely ultra processed food, but I know we have a lot of dietitian here, so looks like the food are relatively maybe healthier than the general population. Yeah. Okay. I have the question listed here, last one for the vegans. I know people are conscious about the diet, but if you look at the vegan diet, they have a lot of so-called ultra-processed food on the market. And it's not necessary the vegan diet is healthy. Okay, the next one, I'm going to spend a couple minutes talking about what we found in the Qatari population, people with diabetes. And it's a study we published recently or last year using data from Qatar Biobank. And we use fact analysis to construct dietary patterns. And we identified the 3 dietary patterns based on the correlation of the food consumption. And the first pattern, we say it's modern. And if we look at the items listed here on the left side, and it's croissant, white bread, cheese, breakfast cereals, fast food, ice cream. And you can see that many of these food in this pattern are ultra processed food. So the modern pattern. And we also have found proven pattern and traditional pattern. So that is based on a so-called advanced statistical analysis, in factor analysis. And what we found here is that the consumption of modern dietary pattern, the low intake, this Q1, and high intake, Q4, you can see the age difference. The high consumption are younger, 46 years old versus 56 years old. But strikingly, if we look at the glycemic control, is that this high consumption group, we have a better control because the poor control is 52% as versus 66%, means this group doing better. But if we look at insulin use at the bottom, what can we find? 30.8% in this high consumption group, they use insulin to manage their diabetes as compared with 28%. Bear in mind, these two groups of people, the age difference is 10 years. 10 years, and the high consumption group, they even have higher, or if we look at the statistics, maybe it's not different, but the value is high. Given the 10 years difference, this data is striking, I would say. And if you look at the association between the patterns and poor control, we can see that surprisingly, well, poor control as outcome, the high consumption of modern diet was inversely related to the poor control. Why is that? When we look at this, because there's an interaction with medication use, diabetes medication. So when people will use medication to control their diabetes, they eat unhealthy, and looks like they had their diabetes controlled, but they have high use of insulin. They consumed unhealthy diet. Maybe that can refer back to Dr. Vijay's question, why the young people, when they have diabetes, they're more likely to die prematurely. Because here, if you look at the graph, is that they eat unhealthy and they use insulin to manage their diabetes. So that is the situation, what we were seeing in Qatar. And here is my take-home message for ultra-processed food dominating the food supply in high-income countries. And UPF are related to many chronic diseases, including diabetes. And we have multiple mechanisms linking this UPF and NCDs. So limiting the consumption of UPF should be given priority. So that is my message I want to convey. So it's not only about nutrients, it's not only about fat or glycemic index or fiber. The food processing, the food additives, they're all contributing to the health. I will stop here and I will seek your comments and questions.
Thank you, Dr. Zumin. There are some specific questions. We've got time for maybe a couple of them. So one is concerning the type of bread. So for which one is better for diabetes, the brown bread or the white bread?
Of course, it's brown bread, but you should go for the freshly cooked, not those the supermarket with a lot of preservatives inside.
Thank you. And then the next question about the role of nitrate in food and the potential harm that they can cause.
Pardon?
The role of nitrates in food.
Oh, nitrate. Yeah. Well, the role of nitrates actually, it's a little bit complicated here. Nitrate, if it is from the vegetables, there are studies showing that the consumption actually is beneficial for cardiovascular disease because it can be related to a low blood pressure. And I know we have a group of researchers in the US, in Australia, that doing a lot of studies in this area, nitrate in the food, if it's from vegetables. Looks like it is beneficial. It depends on the source, I think.
Thank you.
Can I pitch in relates to nitrates a little bit?
Yes, this will be the last point now.
Yeah, the nitrates, excuse me, most of the nitrates we see these days, come from preservatives, especially luncheon meats, sausages.
Yeah.
They are the primary source of nitrates in the food supply. So the theory behind nitrates, especially if they're coming from preservatives, have a kind of bad effect, especially they are related to stomach cancer, gastrointestinal cancer, because these nitrates in the acid environment, they become secondary nitrosamines. So those secondary nitrosamines are actually responsible for gastric cancer or some other type of cancers in the GI system. So I think Zoomin is right, that it all depends on the source. If it is a natural source coming from nitrates coming from certain plants, some plants make nitrates through nitrogen fixation, okay? And those nitrates may be beneficial, but the nitrates that are coming from the food additives might be problematic.
Yes.
Okay, I just want to add that.
Yeah, agreed. Yeah, thank you.
Sure.
We do have further questions, but I think they will be covered in future sessions. So those questions are around the emotional and psychological trauma of the perception of slimness, and around the relevance of BMI around a healthy discussion. So I think they will be covered more in the next diabetes self-management and diabetes complications we have for the next 2 weeks. We do need to leave it there for now. So I'd like to take this opportunity to thank our two speakers today, the Vijay and Dr. Zoomin. It's been a very informative presentation. So thank you both for your time and effort in putting together the content and interacting with our audience today.
Thank you.
Thank you, Dr. Zakaria, for hosting us.
Thank you. And finally, for those who joined us a little bit late, to claim your certification, you'll just need to click on the CPD evaluation, which you can now see on your screen. You'll complete the evaluation and your certificate will be sent to you after 7 days. So thank you very much for joining us. I apologize for the audio delays that have bothered us today, and we'll try to resolve those for next time. Our next session is next Tuesday. We look forward to welcoming you then. Thank you once again to our speakers, Dr. Zoomin and Dr. Vijay.
Thank you.
Thank you.